Hello and welcome everyone. Myself and Sinead, we're delighted to be able to speak to you here today. Thanks to Braun and to MS Ireland for facilitating this very worthwhile meeting. Today we're going to talk to you about living well with urinary and bowel symptoms. I suppose, as you know, MS, there's a whole plethora of different symptoms, but we decided today to talk or concentrate on urinary and bowel symptoms. Obviously, these have an impact on other parts of on other symptoms to do with MS. So we can look at those as well. But I suppose we're going to concentrate today on bladder and bowel. So I suppose first of all, we'll look at some of the statistics and the impact for people with MS. With bladder issues initially. I suppose it's been reported that it can affect up to 75 to 95% of people with MS. However, I would reiterate, and I'm sure Sinead would agree, that everyone is different. It doesn't mean that you're automatically going to have these symptoms or that they're going to be this severe. Approximately 10% of people, when they first present, may have an introducing bladder symptom, but it's often not at this stage of first diagnosis. It can be increased urinary symptoms can be a sign of disease progression, but there are other things as well as MS going on in all of our lives, female, male, depending on where you are in your lifestyle. Have you had children? Are there prostate issues? There's other things to look at. So I suppose what I would say initially is don't presume you'll have all of these symptoms, but the statistics are here, which suggest that up to 75 to 95% may have differing bladder symptoms for people with MS. It is often between, year 6 to 7 as the disease progresses, and maybe that other factors are influencing your disease trajectory that you may become more aware of these symptoms. And the most important thing I would say, I hope we're better at communicating as nurse specialists or within the neurology team, that people feel they can bring up any issues that they're having about bladder and bowel, because these should be normalized as quickly as possible for the person with MS, because we don't want it impacting on your life, and we know these symptoms can impact severely on a person's quality of life. So please, if you notice anything changing, it's important to discuss them, keep note of it, or record them in some way yourself for discussion, depending on how severe they are.
Yeah, I agree, Moira. Hi everyone, my name is Sinead Jordan, and I'm the nurse specialist in St. Vincent's Hospital. I think, just as Moira said, what's really important is that while this is going on for some of you, it's really important that you're not worried or concerned about bringing it up. I can obviously speak for myself, but I think I can speak for a lot of the nurse specialists in that we talk about bowels and bladder all of the time. It's absolutely nothing to be embarrassed about. It's part of our job and what we're trying to do. And the idea is that we can at least, if we can't get you the exact answer to the question you have, that we can at least find out where we can advise you to go. So please don't hesitate.
Thanks, Sinead. Yeah, so I suppose, as we said, not everyone will have difficulties, but for those who do, and if you bring them up, we're immediately trying to find out what are the types. And to come up with a plan of care so that, we can individualize that plan for you. And as I said before, women and men often have differing symptoms within their urinary or bowel, because they are both linked between the two. They're often different, and there's natural aging issues going on with us all. as well. But however, there are more women, or the research says that more women are likely to suffer from stress incontinence than men. But you know, it's the women having the children, so definitely that will have an impact on our pelvic floor muscle, which has an impact on our bladder. So we'd always be saying, bear in mind that it may not just, and I say just in inverted commas, just be your MS causing the problem, but that there's other factors involved. So we want to look at everything when you bring it up with us in clinic. So initially, I guess we should look at normal bladder function. Normally, we don't have to think about voiding or emptying our bladder. We're able to have our drinks, and then when our bladder is approximately 2/3 full, it sends a message to the Pontine Micturition Center in the brain, telling us, I wouldn't mind going to the toilet, but I don't have to go right now. But it's there if the bladder is functioning normally. So then we can obviously wait and go to the toilet at our ease, hopefully. The bladder is a muscle like any other muscle. It needs to be used efficiently, but however, in MS, sometimes the wall of the bladder consistency can change, which leads to a different type of involuntary muscular movements within that. So I suppose, you know, anatomically, the function is either to store it or empty it of the bladder. So there's two muscles within that, the detrusor muscle, and you might have heard of this detrusor muscle because it can be out of sync for people with MS. But this is the muscle that's in the bladder wall that when it contracts, when it gets the okay from the brain and it contracts, that it's this muscle is used to push the urine out of the bladder. Then there's a tap at the bottom of that called the urethral sphincter, and that's the stopper. So that needs to open in conjunction with the muscle in the bladder wall to push the urine out. The tap needs to open, and these muscles ideally work in coordination with each other. However, as you can see, or maybe not see from the diagram, the pathway from when the brain releases, the lesions on your spinal cord when you have MS interrupt this nerve supply. And this is why possibly people may get bladder issues later, or especially if their disease is more spinal cord based, or the lesions are more spinal cord based. And interestingly or cruelly, it's the nerve pathway right at the bottom, which tells the bladder to it's okay to release and pass urine, is just above the spinal cord area for your mobility or your walking. So cruelly, it is often at times when you have started to have issues with your mobility that your bladder starts to, you start to have symptoms or starts to play up as well, which obviously will lead to other problems.
Yeah, I mean, I just, even on that, I think it's really important for people, obviously in discussion and through recording what's going on with them, to define actually what the problem is. And I think, you know, your healthcare professional should, you know, that conversation things you could think about might be, you know, how many times you're going to the toilet, do you get enough notice really, or would you feel safer in close capacity? And things like, do you feel you're emptying? And Moira will go through all of these again, but these are sort of important things to monitor in your own, don't you think, Moira? They're
absolutely
to monitor in your own day to day, because if you come with the better story you have around your symptoms, we can be more specific with the testing and management plan thereafter.
Yeah. And I suppose 70% of people with MS would identify the bladder problems as having a huge impact on their lives. So it is so important to get in there quickly and recognize them and to talk about them. That's so I suppose, as Sinead just said there, it's urgency and frequency are often the initial symptoms as reported. And as well as the detrusor and sphincter muscles individually, these can also play up together. So actually that now I'm not going to be able to say it, but it's detrusor dysinjury, anyway. Sorry now. But where one works out of kilt with the other, and actually for most people, it's a mixture of both, which makes it that little bit more difficult to treat, but there are treatment options there. So overactivity, so that detrusor muscle can be overactive or underactive. It's mainly with people with MS, it's mainly overactive, which can cause the bladder to contract even if you haven't collected an awful lot of urine. So basically that's when you go to the toilet, you feel the urge, you have urgency as well as frequency. So it's that latchkey door feeling that the minute you come in the door, you have to tear to the toilet. Then you feel like you've only passed an egg cup in quantity. And then you leave the toilet and you think, I have to go again. So the detrusor, the muscle is pushing out because it's overactive before the bladder has actually filled at all. If you're going to the toilet more than 8 times a day, you have an overactive bladder. But then we have to look at everything else around that. But that's just the number. And also if you're up twice or more at night, that's too much. So the sphincter can open normally, but it's opening in response to an overactive detrusor muscle, which results in either urgency, or you may have an involuntary loss of urine into your pad or pants. Nocturia then is the other, and as I said, if you're up twice or more in the night, this is problematic for you, and this would cause us to look at and take a history of what's going on within your bladder. And of course, everything is worse by night. So if you're up by night, it's affecting your fatigue, it's affecting your performance at work if you're able to continue work, and it's putting you at risk of falling because you're tireder, and then you may not get back to sleep. The minute some of us lie down, we think we need to go to the toilet again, and you're up again, and it's a vicious circle. So that's the storage dysfunction or problems that people have. With regards to the other side, emptying dysfunction, some people go to the toilet, they think they have finished, and actually then there's a sense that they may need to go to the toilet again. It's the problem here is the urethral sphincter, which doesn't relax. The tap doesn't open while the muscle is pushing the urine out. And the problems associated with this are hesitancy, overflow, incontinence, urinary tract infections, which is a big issue here, looking at bladder and bowel anyway, and it has huge ramifications for your MS, as I'm sure everyone is aware themselves. So we have to always look at possibly having a UTI or outrule a UTI before we discuss any treatment. And then nighttime urine pattern as well, with the emptying dysfunction.
This actually, Moira, just if you don't mind me cutting in there, this can actually be a real issue for people with MS. I'm thinking just of a case I have, and I have a middle-aged female who, a lady I'm working with, and essentially she's had long-standing, presented with long-standing UTIs due to incomplete emptying. And because of this issue, she has really had exacerbations of her symptoms of MS, and particularly is affecting her mobility. And this has been going on for almost 6 months. Now we're still in the process of working through this story or this situation, but what we're finding is that what we need to outrule is really outruling the UTI, outruling an infection, because having an infection, be it a urinary infection or respiratory infection or any sort of infection, can really temporarily exacerbate symptoms of MS, and they can be different for everybody. They can range from, you know, sensory symptoms to mobility issues to whatever, just something that would have already been there. This is not, we do not consider this a relapse. We just consider this what they call it a pseudo relapse, which means a fake relapse. So while for many people it appears to be a relapse, it is in fact just an exacerbation of symptoms due to an infection. You will often find if you contact your MS service, they may say, have you an infection, or can you check with your GP if you have an infection? And this is really important, because if you have an infection and we don't check that and think, okay, this person is perhaps having a relapse, giving steroids for something like this is giving steroids when you have an infection is really not a good treatment plan. So just to sort of say that it is about trying to, particularly with the incomplete emptying, because when the bladder, when the urine is sitting stagnant in the bladder for a while, it's a perfect storm for bacteria. And for it's real, yeah, you know, they love this, and essentially you can easily end up with an infection. So I think even having that understanding behind why, you know, the healthcare professional might ask you to get checked out is important.
Yeah. And that's one of the first things I always ask by phone. I'd say people are wondering, you know, why always, but and a person with MS, after they have settled into their disease trajectory, they know themselves. You possibly can recognize when yourself you think it's an infection, or when your disease trajectory changes. But I suppose what the first thing, because talking about emptying dysfunction and storage dysfunction, a lot of people, the first thing they want to do is stop drinking, because you're going on a journey, you know where all the toilets are already, then you don't want to constantly wear containment products. You want to maintain your independence, but you don't want to stop you doing things. But it does affect your doing things. And the first time you ever have an accident, be it passing water or bowel, you're not, you know, that's etched on your brain. So you're going to make sure that, and possibly you may be doing the things that in fact exacerbate it more, even though it makes sense not to be, because I'm not going to take a drink if I can't go, you know, for a car journey to collect the children. But actually that's the concentrated urine or bladder that is going to make those symptoms worse, because you'll have all the side effects. So in fact, the thing we tend to reduce is in fact the opposite of what we should do. So some of a healthy bladder management is to absolutely make sure that you're drinking 1.5 to 2 liters a day, but it's to look at the type of drinks that you're having and the timing of them. And you know, just maybe like we're all encouraged not to be so hydrated and to be sipping all day, but in fact that's not good for a healthy bladder. And a healthy bladder affects a healthy bowel, so it's all a circle. So you know, you're trying to train your system back, and you can train your bladder like any muscle, and you can train your bowel, and this is what we have to look at. So we would be saying drink regularly, but not sipping. So have a glass of water an hour, or don't, have your fluid load earlier in the day, so that you can time when you're going to go to the toilet. Once you have a glass of water, it actually takes an hour and a half for it to reach the bladder. This, and I know from talking to patients, they often feel, because you have to go so regularly, I've emptied my bladder, I've gotten my keys, I'm ready to go, oh, I'll go again just to make sure, and double void. And actually, again, that's not good for your bladder. So you'd be trying to space out, if it's urgency you're trying to add in more good fluids and space out the time to try and retrain your bladder. Now, physiotherapists are brilliant at this, and often, we would go and or do patient information evenings with the physios, or with some of the continence nurses, if you have the luxury of having them. I didn't up to recently, so we would be trying to advise with the physiotherapist. Caffeine and alcohol are stimulants, and they, we know they cause frequent and urgent urination. Now, the other side of that is, if you're constipated and you have bowel issues, you'll have the coffee to get called to stoop 20 minutes later, and you'll use that to defecate, and that's fine. So I suppose we're trying to balance everything, but we know caffeine and alcohol are irritants, so we'd be trying to discourage them, encourage good fluids. Smoking is an irritant. It's so we would recommend smoking cessation anyway, just for all health, but it is also a bladder irritant. And then a diet varied in fiber, and all the nutrients that you need, which keeps your bowel healthy, is what is required for a healthy bladder. Then I would suggest things like, once you have your good fluids on board and that you're not dehydrated, to look at the timing of them. So 2 hours before bedtime, we would say for anyone is a good idea. Trying empty the bladder then before you go to bed, so you have this like the management of it. And then you're considering speaking to your healthcare provider about, because you think the symptoms are becoming more prevalent. So we would encourage a bladder diary, where you can put down in writing for 2 days. It's enough for 2 days once once you're keeping it up to date, and once it's true, to describe the amount of fluids that you're taking, glass, describe what you think you're passing if you can't measure it, egg cup full, glass full, half a liter, describe it in amounts that you think from your flow. Describe if you were hesitant, if you stopped mid-flow, and try and write all that down, the color of it. This all gives us more information on the day. We will look for a urine sample from you on the day. If you have issues with that, or you think when you come in, if you bring one in, we would always encourage that. And then another self-management, pelvic floor exercises. Your pelvic floor muscle is in a figure of 8. It's holding up your bladder, your rectum, in all. So it's a sling holding up all of that anatomy. So that has to be healthy for both to work successfully. So again, the physios are very good at this. Pelvic floor exercises, most women are more aware of it than men. We would encourage, if you go to the toilet and if you can stop midstream, that's your pelvic floor. That sensation is what you're trying to build up on. People with MS mightn't have the same sensory feeling, and mightn't physically feel that tone or that pull, but that muscle being healthy is optimal and what we want for people who have bladder symptoms. That's one of, and it's the cheapest self-management exercise that you can actually do to try and strengthen that muscle. And this will help with certainly with urinary incontinence, but again, it depends on where you are in your disease trajectory, if you're a man or a woman, your anatomy, if you have prolapse issues, you know, so you need to discuss it all with your healthcare provider. And then, as Sinead said already, recognizing a UTI or a urinary tract infection. Now, I know from talking to people with MS, their recognition is different, and sometimes they don't have the same sensation. They may not get a fever, but symptomatically something is different, and it could be something like spasms. An increase in spasms can make you more aware that there's something going on that's differently. You're, as Sinead said, a query, a pseudo relapse, because you're not quite sure, but there's, and then you're trying to like marry all this up with general progression or versus a urinary tract infection versus side effects from a medication versus spasticity issues and weakness anyway. So, or an increase in temperature for whatever reason. So definitely have that you can describe your urine, you know by the smell of it, the look of it, and have all this history for either your GP or your CNS or your team. Do you have anything there, Sinead, on?
Well, all I was going to say, just on that last slide was, you know, and I think it can depend on your centre you go to or what facilities you're offered, but often, particularly if people in our centre, if people are having issues with emptying and storage both, so essentially they may be double voiding, you know, not releasing enough, prone to UTIs, we would usually refer to or request a referral to the urology team and for urodynamics. So urodynamics, I'm sure Moira's going to go through it, but they essentially, it's just a battery of tests looking at, they might do an ultrasound of your bladder, they will get you to drink, and they want to really see the mechanism of how your bladder is working and what the actual problem is. And that's really to allow a proper management plan to be put in place. And what I notice is that some people, when they approach, so when I have a consultation with a patient, I will always ask about bladder. So obviously in the hope that I'm opening up the question and the person will answer. But often if it's very early days for people and it's just slightly bit different, you know, not really impacting their life, Moira, often people are likely to refuse or say, you know what, I'll leave it for now. I'm not, you know, we'll see how it goes. And that's absolutely fine. However, in these public systems, it can take 6 months to 9 months, even in some centres, maybe 12 months to get that urology appointment. And there's absolutely no harm in having that baseline urology assessment so that we know where you are, so that if, be it 12 months time or 18 months down the line, and we have further issues, we have a measurement, we can measure the difference, the change in your habits over that period of time. And you're also then linked in with the service so that you can literally, you know, it's much quicker to get you back in to be seen as opposed to starting as a new patient, if you like.
Absolutely, Sinead. And I would also add to that, if you've been to your GP and if you've had treated for a UTI once, but especially once or more, twice in 6 months, I would automatically be wanting my neurology team to know that, because treated for 2 UTIs in 6 months is an indication that you need to have a bladder assessment. Some people, you know, would report to or have reported to me in the past I had a bit of an accident when I was laughing or coughing or sneezing, but it only happened once or twice. Or if you have a sense that you're not emptying your bladder properly, this can develop quite, quickly, or should definitely be discussed, because it can develop into urinary problems and these need to be looked at now rather than later. And as Sinead said, there is urodynamic testing. I suppose if after having a PVR, which is a post-voidal residual measurement of urine, that the neurologist or your treating physician is happy that it's overactive bladder management with no storage issues, they may prescribe antimuscarinic medications such as these, or there's a few more regularly used, which will block the contractions of the detrusor muscle in your bladder, so that overactivity will be dampened down. That's what these medications do. There are side effects, however, and one mightn't suit you. And definitely, if you start one, I would be self-monitoring, and you need to feed back to your team or to the prescriber how you felt they worked or didn't work. So some of the side effects dry them out, and they titrate these doses. They're taken in different ways. Some are patches, some are slow releases, some are, so you need to discuss what suits you if that's the route you're going down. Now, if you have a mixture of both, that dysarthria that I can't word, that I'm still, I'll be able to say once this is over. If you have the storage issue or both, it could exacerbate problems by impairing your already poor emptying ability. So that's why I say if we're fully sure that it's the muscle hyperactivity that you're treating, well then a lot of people are prescribed these medications.
I just want to jump in there on the medications. And while, as Moira said, a lot of them are for, to block the message that start the bladder contractions, they can be different. So for example, some of you might be on the likes of Betmega, and essentially this is really, it works by relaxing the bladder muscle. So it allows the bladder to fill, before that contraction, and that might work well for some of you. There's side effects, as Moira said, and that might not work. Like another common one used is desmopressin, which has been around a long time. And essentially, that's sort of, it's a synthetic hormone, really. And that actually reduces the amount of urine the body produces. So while they all have the same effect, or ideally have the same effect of reducing the frequency, they work in different ways. So again, don't be worried or frustrated if one doesn't work for you. It's just really about, working out what's the most appropriate treatment for each person.
So then we go on to another treatment, which I'm sure a lot of people have either had or come across or certainly discussed. It's Botox of the bladder. So this is often used. It's licensed for people who are retaining urine. So it's often done as a day procedure. Urology will decide this. You'll have had your urodynamic testing, and then I suppose it is to you go in as a day case. It's injecting Botox into the bladder wall. I think between 21 and 30 injections around the detrusor muscle, and it reduces this overactivity so that your bladder can fill, and patients have reported huge improvements in quality of life, in my experience. after having this done. But I suppose there's three different things. It can work perfectly, it can not work and to make no difference to the detrusor muscle, or it can work so well that actually you don't void, or you're not emptying your bladder properly, so that you need to be able to do clean intermittent catheterization. That's one of the precursors to it. So any one of our patients that we're looking or have had this have to have done the education about clean intermittent catheterization. Now, depending on what team you have in the hospital, I certainly would have gone through the principles of it, but actually most of the patients, if they didn't see an incontinence team or nurse, preferred the option to be shown this at home. And some of the companies provide this service of home care nurses to do this in the home, which is brilliant. When I was in Tralee, I had a lot of contact with the home care nurse from Limerick. I don't know if he's still working in that capacity, but myself and himself liaised an awful lot, which was brilliant for patients, because the minute you say catheter, people get nervous. You know, previously you had a catheter, you never got rid of it. Now there's some people don't need to catheterize with the Botox, which to my surprise is brilliant. And people, you know, it lasts 6 to 9 months, so you would come in again and have it done. Some people did have to do the intermittent catheterization, were taught it in the comfort of their home, but then it wasn't such a huge barrier to them, because actually now you can do it intermittently, as the word says. You can do once, twice, or 3 times a day before you go to bed. Once you get it, you really get it. And that, as reported, especially from males, because there was a huge barrier initially from men thinking they would never be able to manage it. However, once you're taught, and once you're taught well, and then you have the luxury from a patient perspective of contacting that person again who visits you in the home, should you need further support, I suppose. So for the Botox, and actually the fear of infection is less doing intermittent catheterization than having an indwelling catheter or having multiple UTIs. So actually, once you can manage it, and patients report different things to you, what they fear, and actually when they have it done, the freedom of not having to scout for toilets for every 20 minutes, or being able to go back to work, or being able to take up a hobby again that they felt they couldn't do because actually I need to have the toilet within, you know, every 20 to 40 minutes or whatever amount. The positive report backs for the catheter, even though this is what people are scared of, if it works and it's in and out, or it's even on a block, a flip flow, it has changed dramatically from what people consider long-term catheters. Would you say, Sinead? Yeah?
Well, yeah, I mean, obviously, we've had a lot of positive outcomes with Botox. I think, you know, if the tablets aren't working for people, if they're still not getting sufficient reprieve from the constant urge to go, or, you know, really when emptying is, you know, it's more urgency really, and it can work extremely well, as in life-changing for some people. I think in terms of the catheterization, obviously it's more, as Moira said, in relation to where you're retaining, you're not emptying properly, and obviously, you know, risk of UTI. But actually they have the devices they have today, the speedy cats. I mean, women will, I guess, be able to understand this more, but they're so discreet. They're like essentially the size of a tampon, individually wrapped. They can be, you know, put in your handbag really simply, and it's, once you get the knack of it, Moira said, it's very simple procedure, and can really change your life, because the things like the waking up at night, the frustration, and it puts you in bad form, and it can really affect people's mood and self-esteem around all of these things. And I think it's because, and I'm sure it's across the world, but in Irish society, there's a big stigma around anything to do with our private area, be it urine, bowels, sexuality, anything like that. It's all a taboo for a lot of people around it. They're embarrassed to talk to a healthcare professional, which we are. I mean, I hope us being here today shows you that we're able to talk about this, that this is sort of a normal day-to-day part, and we're here to try and help. But it is very discreet, and it's not something to be feared, as it can really, I guess, it can, if it's embraced, it can really be life-changing.
And improve independence, which is, you know, I mean, that's the whole point, that something that's affecting you, that if you can't cure it, you can manage it, and then it doesn't have this whole impact on your life, and as Sinead said, affect other symptoms of your MS. So management of emptying, again, you've reported it to your team. We've dipsticked for a UTI. Some people have their own dipsticks at home, or drop samples to their GP. Obviously, if there's nitrates or leukocytes or blood in it, they'll treat you for urinary tract infection. On for the urodynamic investigations, which we've talked about, but the main thing being your own record and of your bladder diary and your post-voidal residual urine scan, which some CNS, some MS nurses do, some incontinence or some urology, it depends. And then we would advise, if we know urodynamic testing is coming up, we'd advise people, you know, to drink properly in the days coming up to it. So like I would say, definitely have drank 2 liters the day before. Then the day you come in, you drink like 2 big glasses of water. You instruct your patient then to obviously void, go to the toilet and measure it, and then you're scanned immediately afterwards to see what is left behind. And then depending on, you know, there's, you know, well, anyway, the parameters are slightly different in probably every center, but it's somewhere between 100 to 150 mils. If that's left behind in your bladder, well, that's a source of A, infection, B, you know, it'll affect your kidneys. So then as we said previously, making sure you're drinking, and drinking water. And look, if you start drinking, obviously, if you're someone that has minimized the amount of fluid you've been taking, maybe swap good fluid for, you know, bad as in, you know, caffeine heavy drinks for water, and then gradually increase it up. Like, you know, no, not everyone's going to drink 2 liters and say, you know, that's ideal, but I don't do it myself some days, you know. So you'd try and increase up gradually, but that your urine is a healthy color. It should be straw colored. It shouldn't be odorous, and, you know, not concentrated. So you know you're drinking enough for yourself, even if you don't make it to the 2 liters. So I suppose then looking at, if it has been decided that you have a storage issue and you are doing the clean intermittent catheterization plus or minus the Botox, it is considered gold standard, less chances of infection, you become the expert yourself. And you will know how many times you need to do it once you start doing it, because you'll know with the volume. Definitely to carry it out bedtime, to try and improve the nocturia. As I said, anyone that's up more than twice a night, it's, you know, you're going to be affected the next day, and it's going to have an ongoing effect on your MS. It's the worst part of it, the nighttime frequency. stroke incontinence. It's you know, it's so debilitating. Everything is worse by night. The desmotab, as Sinead said, is often what's added. You should only take that obviously once a day because it stops you producing urine, and carrying out clean intermittent catheterization before bedtime, so that you know your bladder is empty. You've gone to the toilet, you do the catheterization if that's the regime that you're on. You know your bladder is empty, and you know, obviously nothing stays the same. Sometimes in advanced disease, we have to look at more long-term options. People might go into retention. That for whatever reason may be a short-term thing. You can have trial without catheter, but you may end up requiring a longer-term catheter. This is for people whose disease has progressed. But we've looked at all the other options, and we're seeing, or I certainly think, I suppose less and less people are requiring the long-term care of that they used to require for bladder management if they report it early, and if we can get a handle on it. But look, everyone's different, and it depends on the severity of the disease as well. But suprapubic catheter is more prescribed for long-term people with catheters now. It's where you go into the abdomen. It's changed every 12 weeks. Some of the CIC teams change it them in the community. Some of the MS nurses change them, or the conscience nurses, or urology, depending. And I suppose the same goes with if you have a suprapubic catheter. You need to drink plenty, take care of the site, and ensure you've no UTIs. So I suppose in summary from me, bladder issues are common for people in MS. As I said at the beginning, it doesn't mean you'll have all of the symptoms. What it means is once you know they're common, and if you think you're developing symptoms, please talk to your healthcare provider as soon as possible. Outrule infection in your own head, so go give a sample into a GP if something changes acutely for you. That's what you'll be asked on the phone if you're talking to your MS nurse. There are many treatments, many medications, and containment products, and you might be like 90% of the problem might be sorted. You still might need, for security, to wear a containment product. That's okay if that works for you. I mean, you're trying to maintain skin integrity, so you're going to use the best products that you can, but you know yourself what you need. You're the MS expert. And I suppose what I would say is have the conversation early. And if you can't say it to the neurologist, or your appointment is too fast, or you don't think of it till afterwards because it's something small, like I sneezed and I had a bit of an accident, or it happened twice, or we were coming home late, and for whatever reason, talk to your MS nurse and just start keeping a bladder diary and make notes to discuss it for yourself in your next appointment.
I was just going to say on that, I think one of the, obviously, I imagine one of the most common concerns for people with bladder issues is the worry or the fear of bladder accidents, you know, and obviously what that entails and how impacting it can be on their lives. I think just from a common day-to-day thing, certain things like the clothes you wear, you know, maybe avoiding buttons on your jeans, you know, a Velcro or an elasticated tracksuit or something might, you know, if you, for that rushing, just to have something where you can easily take off when you're going to the toilet. And as Moira said, things like there are a convene, or they call them the condom catheters, which essentially are used for males, and then a leg bag is attached. I mean, that can be really life-changing for somebody who has accidents, for males who have accidents, and they can wear these. There are also handheld urinal devices available for women that can be used discreetly when they're out and about, and it's definitely worth looking into it. I'm trying to think of the name of, there is one of the pharmacies that deal with all of these things, or of course if you're in touch with your incontinence nurse or urology team, they may have a specific, they could refer you, they could give you the details of how to obtain these. Yeah.
Or Roz, the nurse in the community, will have all the tricks.
Oh, you should be on later to tell you. Yeah.
Lovely. That's the end of my slides there. Sinead, you have some?
Yep, I'm going to do now.
And I suppose just while Sinead is doing that, like in clinic, I wouldn't separate bladder from bowel. We'd actually, I don't know about you, Sinead, but we do the two together. So, because one does influence the other, and one being worse will have an effect on the other. So I guess I'd talk about them both together normally.
Yes, they do. They come hand in hand, bowel and bladder, really. Certainly for me, anyway, when I'm talking about it. So, I mean, I've obviously been interrupting Moira through her whole presentation.
That's all right.
So I'm Sinead Jordan. I work as a clinical nurse specialist for people with MS at St Vincent's University Hospital in Dublin, and I'm a registered advanced nurse practitioner. So today I'm going to just go through bowel management, and while there may be similar things in terms of what's recommended for bowel and bladder, you'll see as I go through. And just to say that bowel dysfunction, it does not appear to be associated with the degree of disability. However, it can be associated with the duration you've had MS. So it's not a very common initial presentation problem, or it wouldn't really ever be. It's something that over time happens as the longer you have MS, or I guess the type of MS you have and where your lesions are dispersed through your brain and spinal cord. However, it's a huge ongoing distress for people with MS, as you can imagine. So I'll just go through these slides now. And obviously, as Aoife said earlier, we'll go through, I see there's questions popping up there, and we will try and address as many as we can at the end. These are just my disclosures for educational support. So the statistics, the research shows that up to 70% of people with a diagnosis of MS complain of constipation or fecal incontinence throughout the disease trajectory. And often due to embarrassment, or if it's not addressed by the healthcare professional, it's often underreported. There's many problems, as I mentioned, many causes, potential causes. It can be due to your nerve damage. It can be due to where that essentially the message, similarly with the bladder, is not getting from the brain down to the anal canal, and telling it it's time to empty the colon area. And you may just have a weak colon muscle, or reduction in peristalsis, which is the movement of the bowel that pushes the waste out. Similarly, there's obviously there's secondary issues that can be actually adding to these problems. So it can be side effects of existing medications, often pain relief, or medications used for mood can often have an effect of constipation. Using laxatives, overusing laxatives can also cause this problem. And if you have bladder issues, when we're talking about the sphincter area and pelvic floor exercises, it can all be related. Secondary issues in terms of incontinence, similarly, if it's down to fatigue or if you have mobility problems and difficulty getting to use the bathroom facilities in an appropriate, in a normal time. Similarly, I'm going to just talk about what a normal bowel function is. So what we would consider normal is that you have a maximum of 3 bowel motions or stools per day. And while I might personally think that's a huge amount, some people, I mean, if you've people just generally in the population, people can exercise a lot or down to their diet, their water intake, or can be hypermetabolic and just go to the bathroom a lot. Really minimum amount is 3 bowel motions per week. Anything less than this, and you obviously have abnormal bowel function. You should be able to pass your stool with minimal effort, in that while you may squeeze slightly, it shouldn't be causing any huge discomfort. It should not be tearing the inside of your rectum, and there should be no blood or mucus present. Just in general around that, good measures to keep a normal bowel function for those of you listening in who may not have bowel issues is it's important, again, the fluid intake. And it's important to try and, obviously your body absorbs the fluid, into the stool, is then to make it softer and so on. Having a healthy fiber-rich diet. Exercise is vitally important for day-to-day life, but also even just, I realize that, some people may have mobility issues, but anything, no matter how small it is, even walking out to the end of the road and back, or out to the garden and back, anything at all to try and just get moving. Obviously, if you don't have any mobility issues, the recommendation would be in line with the Heart Foundation, in that it would be 30 minutes exercise 5 times a week. Another measure would be that if you're having any problems, we can have a look at medication to see if that's having a direct impact, and then also looking at your bowel routine itself. So this slide here is just giving a demonstration really on how the bowels work itself. And I hope I'm not insulting anybody by just going back to the basics on this, but it might be helpful to some of you. So essentially the bowel is part of your digestive system, and it has 2 major functions. The first one is obviously eliminating waste, through defecation in a usual time frame. The other is obviously digesting your food, and then your body will absorb whatever vitamins and so on it needs out of it. And then the rest is essentially passed. So the digestive system obviously goes from the mouth down to the anus, and the large part, well, you can see there the colon area down on your, I'll just sort of maybe move my thing. Here is really where, this is the last section where your feces is stored until it's ready to be passed, until there's sufficient there. You can sort of see here this thing. This always reminds me of what the peristaltic movement of the bowel is, and how it's trying to keep the motility of your stools, and to try and get them to move through.
And just there, Sinead, I suppose the important thing is the longer it takes for it to move down, the more dehydrated it's that stool is becoming, because once it leaves the stomach, it's that waste product is becoming like the all fluid is being taken out of it. So the longer it takes in transit, and the motility of it there affects how the end product is going to look like, feel like when you're trying to expel it, And there's the difficulty, because it's, in my experience, it's more people reporting constipation or overflow because of constipation than actually diarrhea.
Yeah, no, absolutely, absolutely. And I mean, actually, as I guess waste builds up in your back passage, in your rectum, you know, it stretches, and that's actually what triggers the message to your brain. And this again is what Moira said, is when we're talking about where your lesions lie, you know, if there is damage, if you have inflammation, anything there, the message sort of has to either doesn't get through at all, or it takes the sort of long way around. You know, it's like scenic route before it gets there. So you're, you know, it's just not working efficiently. Mm-hmm. So essentially, two of the main issues really, as mentioned, are constipation or incontinence, really, which can be very distressing. Again, and I guess if you're having bowel problems or urinary problems, while these might seem just adding to your day-to-day, I guess if you're having problems, this is not going to be too much of a challenge or an issue for you to follow out. It's really important to keep a bowel diary, and I'll show you some pictures now in terms of actually what the consistency of the stool like. So you might be able to, you can take a picture of it, you might be able to describe, you know, what your stool looks like. Really looking at what your diet's like. I mean, if you're not drinking enough fluid, you're going to have dehydrated feces, you could have constipation, slow peristaltic movement. If you're not having a healthy diet, and a healthy diet is your Mediterranean diet. I know there's lots of diets people use, but really when we're talking about a healthy diet, we're talking about just a healthy, you know, fruit, vegetable, fiber, that sort of thing. You know, things like you can add linseed oil, and there's lots of different things out there, you know, that I'm sure you're all aware of. But it is looking at trying to have that 6 to 8 glasses of water, ideally water, but you know, if a couple of them are tea, coffee, you know, so be it. At least it's something in. Some people might find using some dilute or something if they're poor water drinkers. But it's sort of important to have a look at what you're doing, particularly if you're having problems. And then the defecation dynamics. So this is really how that process of you, or what it is like for you, which is very individual in terms of going to the toilet, you know, how long it takes, you know, how long you're sitting there, so on. We could look at your medication. Again, mobility, lack of mobility or poor mobility, lack of exercise will slow down the bowel peristaltic movement, will slow down. And also looking at, some people have had bad bowel habits all of their life. Like, this isn't new because of MS, and that's valid too. It might not be directly related to your MS, but it might just slightly have worsened. So if you look at this next slide, so I'm just going to look at correct positioning. So this is actually what's called, and actually I think it sort of sometimes sounds a bit vulgar, but it's called the brace and bulge technique. So this is really about getting into the correct position to have an efficient bowel motion, if you like. So you can see there, step one, you know, maybe if you had a little footstool or a box or something.
I think isn't it, Sinead, that your knees are above the height of your hips is the ideal position. So your legs may not be long enough if you might need a footstool. For optimal. For optimal.
And then in step two there, it's that you're leaning forward. So I guess you're putting pressure down on that lower abdomen area, and put your elbows on your knees. So the third one there is they talk about, so it's pushing, it's bulging out your stomach. So it's pushing, it's that straining technique, the pushing, and you'll feel your stomach bloat out, push forward. And then and straighten your back. And this is the ideal position for your body. Like, I mean, naturally our bodies would be I guess, you know, bathroom facilities, it would have been the squatting technique, where people would have squat. In some communities, people still will use squat toilets on the ground, you know, in the Middle East. Here on the right, I've given some lovely pictures of, I'm actually just going to try and move sorry, now I'm just trying to hide these for a second. So just looking at the type, this is just a good idea in terms of being able to describe to your healthcare professional what your actual stool is like. So whether it's sort of small rabbit-like sort of stool like this, whether it's dry on the surface, whether it's smooth and soft, if it's watery or coming out. So this is the Bristol stool chart, and is very useful to try and at least have some sort of label, I guess, or to be able to identify exactly where you're at with.
So you can, that you can guide your healthcare provider into what you think it looks like, the consistency of it, because then we know what stage of, whether you need, dietary changes, medication, intervention, how it's affecting you, if you're straining, if you're spending too much time on the toilet, all of that. And I mean, anyway, I'm sure Sinead will.
Yeah, no, it is. It's important to give yourself time, not to be rushing. Like, if you're rushing it, so if you're trying to go out to work or you're going somewhere, it's important that you make the time, that you have time to allow it all to happen, that you're not giving yourself 5 minutes. You need to allow yourself time. You need to feel comfortable and relaxed, and not to force or strain it. It should come naturally. And I guess really, they say that the best time, again, and actually I saw a question there came earlier, was in relation to, training your bowel. And actually there is there's a whole thing on training your bowel, and in terms of planning when you're going to at least try. So the most efficient time to go to the toilet is after breakfast, actually. So by avoiding breakfast, you're not doing yourself any harm, you're not helping yourself. So if you have breakfast in the morning, and then roughly 15 to 20 minutes after you eat, in general, you should be able to pass a bowel motion, and breakfast is the optimum time. I guess if you're sitting on the toilet for 10 minutes, I would say stop at that point, and give it a break, and maybe wait till after your next meal and try. Like, establishing a regular routine is really valuable, particularly for constipation, at least when you're trying. Along with perhaps maybe some laxatives or something. Abdominal massage, like rubbing your tummy, to try and encourage it to move through, can help. They say that when you're to effectively massage your tummy, that you should rub your stomach in a clockwise motion with the heel of your hand, press to ground. Start gently first, but if you need to, you can be much more firmer up the right side of if you go up the right side of your abdomen and then across your belly, and go down in that position, a sort of massage across that for about 10 minutes. That can actually help stimulate some of the peristaltic movement that should be there. As I mentioned, another thing obviously is the review of medications. I'm sort of going into this again. So it's sort of looking there at what your diet and fluid is like, keeping that diary, keeping the diary. Your defecation dynamics is really how you're doing it now, and maybe looking at the use of the gastrocolic reflex. Is that sort of natural urge to feel like you need to defecate maybe 15-20 minutes after food. So pardon?
Sorry, Sinead.
No, go ahead. No, please do, yeah.
I was just going to say, sometimes, because we're all busy and we all have lives, and all these symptoms take time to manage, and you're trying to get into a routine. Sometimes if we're rushing, we can put off going to the bathroom. So you might not be maximizing that that reflex if you're rushing, and you might think, oh yeah, no, I haven't time. Like, you can put it off. It's like a muscle, your bowel as well. You can train it to go when you want it to go if you're relaxed enough. But if you've got out of that habit because of other you know, family life or turn, you know, kids when they used to go to school and stuff, that actually you need to get back into that bowel management and allowing yourself time. Because if you get back into the routine of this, and that it works satisfactory, be it with some aids or medication that needs to be, but if you can manage it, well then long term, you know, you won't have accidents or the fear or the worry or the constipation. So you're trying to get back into that habitual, and you know, like if you're distracted, even though I'd be giving out anyway if anyone takes a phone into the toilet, but you know, there are studies that say actually if you know, if you have a magazine in there or something, that sometimes that can help distract to actually the body's natural guard let down to allow yourself to go to the toilet.
Yeah, no, absolutely. I mean, no, absolutely. So it is important to make time. Also, when we talk about medications, even some of the medications that you might be put on for, you know, your bladder, or spasticity, even iron, you know, anyone who takes iron, I mean, that would constipate anyone, you know, if you're taking Galfer. So these things are consideration as well. Digital stimulation and manual evacuation. Obviously, this may be useful for people, particularly who maybe have mobility issues or who just can't defecate. And this is really you just using your you know, a gloved hand to try and remove the maybe harder outside you know, stuff near the exit of the rectum, to see if that will help. There's also a procedure which I'll go into briefly now, rectal irrigation, which is a washing procedure of trying to help clear out the bowel. I guess some of you might have heard of a thing called colonic irrigation. It's something similar to this. So I just wanted to sort of say in terms of commonly used laxatives, these can be issued by your GP. Most of the I actually wanted to say it in terms of bladder as well. So most, everyone who has a diagnosis of MS is entitled to a long-term illness card, which will cover the cost of any medications or devices, or a certain amount of them that are required for your day-to-day needs. So I think if you look up on if you Google essentially the long-term illness list J, I believe is the MS list, it will give you a list of all the medications and all of the devices, including types of catheters and so on, which are covered by your long-term illness card. The long-term illness card is available through, you can Google it and download the form and send it in yourself, or if you ask your MS nurse, they'll send one out. It needs to be either or your GP, often the pharmacy have them available as well. It needs to be signed by your healthcare professional, so either your either the consultant or your GP, and it takes about 3 weeks. It takes about 3 weeks roughly to get the number. Once that number is registered with your pharmacy, you're covered. I'm sure most of you know this already. So just looking at these, like Fibogel, I'm sure if you read through these, some of you are familiar with these. So Fibogel and a word I can't properly pronounce, I'm probably going to pronounce it incorrectly. It's Isfagula husk. You can get it in the health food shops. These are bulk forming laxatives. So essentially these type of laxatives increase the amount of feces by absorbing water through the gut wall, and it also will stimulate that peristaltic movement. So that's movement of the gut wall. Sorry, I'm just demonstrating, but that movement of the gut wall to allow it to push the feces out. Lactulose and Dufalac, these are stool softeners. You might be familiar with these. They're liquid, they can be quite sticky, and you can take maybe 10-15 mils up to 3-4 times a day. And these sometimes can give you some stomach cramps, to be honest. And again, how they work, they absorb the water through the gut wall to make the feces a little softer and easier to move. Movicol is used really well. Its recommendation is for chronic constipation. And again, it's similar mode of action in that it increases the water content in the bowel, and thus softening the stool. These are sachets which you pour in with water and mix. And I guess if any of you have ever left it, it sort of then can look like what I would imagine, or what I remember wallpaper paste looking like. So what this does is it sort of, you know, this is very commonly used with good effect. Sometimes you might need to mix different laxatives, you know, maybe take your Movicol during the day and then take a Senecot or something at night. These are Senecot and glycerine suppositories are stimulant laxatives, and they will stimulate the rectum to obviously help push out the feces. Microlax enemas, often used, I mean, people who use them at home. I guess my experience would have been on the wards using them, and this is when people are just not able to empty completely. So essentially this will try and empty the whole bowel, and initiates that urge to pass. Side effects again vary from person to person. However, certain things which I've mentioned there are just stomach pain, maybe slight bloating. You could have a little bit of nausea, stomach cramping, or flatulence, which is passing of wind. And that on its own, again, you know, can be another problem for people. You know, the embarrassment of excessive flatulence due to constipation, or you know, again, this is things to look at in diet. Certain things in your diet can add to maybe the odor, and there are, I guess, sort of deodorant type things that will cover this specific smell if it's an issue for you or causing embarrassment. So I'm just going to briefly talk about the non-surgical and surgical interventions that can be used. You know, again, these are going from one extreme to the other. So bear in mind that for most people, these won't necessary, you know, any surgical interventions won't be necessary, but it's just to let you know that there are things there if it becomes really problematic for you. So transanal irrigation, I'll show you on the next slide. This is essentially, it can be done at home. It's a process of essentially flushing out your system with water. It's also known as rectal irrigation, and it involves basically you put warm water into the bowel via the anus using a catheter while you sit on the toilet. So essentially it washes out the feces out of the bowel, and encourages the urge, you know, so the bowel will actually help push it out. There is lots of these systems available, so you can speak to your healthcare professional in terms of which one they recommend, or, you know, and again, you can see which one you're covered for your long-term illness. The anal sphincter exercises are similar to the bladder ones. You're looking at your Kegels, your Kegel exercises. So you have two sphincters in your bowel as well, and one of them which you've no control over, and the other which you do. So in the event, for example, when you're outside and you suddenly feel you need to go to the toilet and you're able to hold on, that's the part you have control over. So looking at that, it's really, you know, you're looking at really getting that positioning right. This can be done. You can either sit, stand, or lie down while you do these exercises. You would slightly have your knees apart. And then if you, it's that sort of feeling of pulling up. So as if you were trying to stop yourself from passing wind, say, that feeling, and you hold it up and try and hold it for at least 5 seconds. And that's how you're going to practice that. And this must be practiced quite regularly, you know, to have an effect. Obviously, like any other muscle in your body, the more you exercise it, the stronger it becomes.
I think 3 times a day is what the recommendation is, for 5 to 10 minutes if you can do it, you know.
Yeah, well, I think obviously putting this time aside initially to make sure you're
Yeah.
doing it properly, and until you're comfortable with it. But actually, it's something you could do when you're in the car,
Sitting down,
and
yeah.
have triggers. Like every time you're at a stoplight, you go, oh, you know, something that you could, you know. But I know that sounds insane, but it's like it's trying to build it into your life. Nobody's going to know you're doing them, you know. So, then we have the chronic enemas, which again is sort of medication we've gone through there. Colostomy bag, I guess, is a surgical intervention in the event that there's really we've exhausted every other pathway, and really, you know, this is really then for comfort and for skin integrity, and it's where the formation of where they form a bag on your abdomen, or form a stoma, sorry, I couldn't think of the word, on your abdomen, and essentially then you'd have a bag, and your feces is passed in here. The sacral nerve stimulation and the percutaneous tibial nerve stimulation are modes of they're gadgets that can be used to try and stimulate these nerves, which can which can help you
improve your
control
function.
and improve your function. Yeah.
Except there's a time, anyway, there's a time that you have to sign up for 12 weeks of 30-minute type sessions. So there's, you know, there's a, you have to agree to a certain program there. It's not a quick fix or that.
Oh yeah.
It has shown to help.
To help. I mean, I guess it's working out what works best for you know, yourself. Yeah. Sorry, so I have here just a little picture, and this is on the peristine or the cophora. So this is sort of the kit, the bag that you have at home, and the end of this tube, it's a lubricated tip, and then that's just placed while you're sitting on the toilet. You place it into the rectum, and then you flush it through with water. And this can obviously help clear anything that's backed up in there and clear the line of your bowel, and can be very useful, I believe. So I guess just overall, when you're looking at the management of fecal incontinence, I guess we need to consider, is it incontinence, or where that you've no control at all, or is it that you're just so backed up, as in overly constipated, that it's just leakage around that? It's again looking at medications and diet, obviously, that need to be considered. Then looking at the containment products. So for bowel, obviously, you're looking at pads and so on. They also have an availability of anal plugs, which can be used for periods of time, up to 12 hours a day, or just for shorter periods of time, that if you're worried going somewhere, particularly about leaking, that it will just prevent, and it will sort of keep it at bay until until you're home and feel, I guess, a bit safer.
Which are brilliant, because you don't have to worry about odor issues, and they come in 2 sizes. They're very practical. And anyone that it's like a tampon size, anyone that has used them has, if they can tolerate them, find them very effective. Because, like I say, you know, if you do suffer a leakage, it's not odorous and not coming to the air. You're not in a pad, you know. So for security and practicality, works very well, from what I've been told.
Well, no, absolutely. The other so the things really are things like non-surgical interventions, like the pelvic floor exercises, the your diet, increasing whole grain fiber. It can help bulk up your stool, reducing caffeinated drinks, coffee. Obviously, as Moira said, it can be useful if you're constipated, but if you are on the other side, it's a trigger. It can be a trigger. And I guess it's establishing a routine on regular times, maybe around the use of laxatives and stuff like that. Another Imodium, which you may be familiar with, is a medication that can help. It can be used to slow down the movement of feces through the intestine and makes it more solid. So it might give you a little bit more control with that. And as we said, surgical interventions obviously are colostomy. But just there, I've said that early reporting and assessment can lead to more satisfactory outcomes. So it's really, I can't really say that enough, that obviously the earlier we can get people in with the right people, you know, at my site, we would often, if people are having extreme problems that we can't get control of, we'd refer them maybe to the gastro people for an assessment. You will also find useful links and support material. The MS Societies, you know, is an invaluable resource here in Ireland. The HSC websites, and also the MS Society in the UK and the MS Trust in the UK have really good websites as well, where you can get some good information. I hope that you have all received benefit from this talk today, and we'll be here to answer your questions shortly. Thank you very much.
Hi, good afternoon, everybody. My name is Susan Cleary, and I work as one of the sales specialists for Braun Medical. So what I'm going to do is talk to you about what we offer at Braun and our catheters, and it's all around ISC, which is intermittent self-catheterization. So basically, Aoife, sorry, there. Are you okay? My computer has frozen.
Okay.
Oh,
we're doomed.
Weird. God, it's working now. Sorry, now I'll have to start again there. Sorry.
You can start again, no problem at all. Okay, so I'm just going to mute myself, and you can go from the beginning then whenever you want. Okay. Okay.
Fine. Hi, good afternoon, everybody. My name is Susan Cleary, and I work as one of the sales specialists for Braun Medical. And I'm going to talk to you about some of the products we offer at Braun. And we provide a selection of catheters for ISC, so that's intermittent self-catheterization. So basically, just what is ISC? Basically, ISC is the passing of a small hollow tube, which is a catheter, into the bladder. And that can be passed either through the urethra or the abdominal wall, just to drain the urine, and it's removed immediately after. So it's only temporary. So basically, you insert the catheter and remove it straight after and discard it. It can be performed by an individual or by a parent if it's a child or a carer. The bladder then is emptied. It's emptied then at regular intervals, and that can range from maybe once or twice a day up to maybe every 4 to 6 hours. And our catheters then come in different sizes, lengths, and types. Bladder dysfunction then, as Moira and Sinead said, can happen or occur in at least 80% or over of people with MS. So basically, you know, that can have a physical impact and a psychosocial impact on patients. And, you know, just around the physical impact, that can have, you know, you can have impact, you know, with skin problems, UTI, sleep disruption or sleep loss, especially if you're up at night with frequency, or in extreme cases then maybe kidney disease. The psychosocial impact then, it can affect your work, you know, your ability to exercise. It might put you off traveling, socializing. It can have an impact on your relationship, your sexual relationship, and it can cause then anxiety and depression. Just some of the patients then who do use ISC and use it successfully are maybe patients that might have a spinal injury, patients with MS, Parkinson's, you know, after surgery. There's you know, there's a lot of patients out there with varying conditions that do use ISC. The criteria then for successful ISC then would be, you know, you do need to be motivated and have a willingness, cognitive skills and an understanding, and manual dexterity. But, you know, partners and caregivers can help with the procedure. Some of the advantages then, there is advantages of using ISC. You know, it can reduce the amount, you know, the numbers or the amount of UTIs you might be getting. You know, a good technique and, you know, frequency of use. It does decrease or can decrease the risk of kidney damage. It will improve your quality of life and your independence because you've got more bladder control and complete emptying. And it's discreet and convenient, so nobody needs to know you're even doing ISC. And it will have a psychosocial aspect because, again, it's reducing the risk of urinary leakage. And another aspect, then, it can allow you then to have an easier and more spontaneous, you know, sexual relationship with your partner. And then it shouldn't hinder you then from social activities that it might have done before. At Braun, then, the products then we provide at Braun, we provide, again, as I said, a full range of catheters for ISC for pediatrics and adults, both male and female. And we can teach patients then how to use the products, you know, in their own homes, clinics. But you have to be seen by a urologist and nurse specialist, and a complete assessment is normally done before you're referred on for ISC. We can act as an educator and a support person for patients. And we also have key contacts then with our urology departments throughout the country, and our urology consultants and our nurses. And then again, all our intermittent catheters are available on the GMS. So they're all available then, you know, by your medical card. Our brand at Braun is called the Actrine brand. And it's made up, as we say, the Actrine DNA. So it's all about patient safety, patient autonomy, and the low environment impact. So just in relation to patient safety then, we have a unique lubrication formula, and all our catheters come pre-lubricated. So you don't have to worry about lubricating your catheters, water, mess. The catheter material itself then is latex and PVC free. There's non-traumatic eyes on the catheter itself, and there are no touch catheters. Just around the lubrication then, the lubrication formula is basically glycerine and water, so it doesn't dry out when it's opened. So that allows for a kind of smoother insertion of the catheter, because it does hold the moisture for a longer time. Most of the catheters will dry out within the first maybe 10 minutes. The Actrine catheters will stay lubricated for up to 60 minutes. Again, around the lubrication, for anybody that's considered maybe starting a family, the lubrication on our catheters, they have no effect on sperm. The lubrication, again, doesn't interfere with urinalysis, and there is no residue then left in the urethra after you do catheterize. So again, you know, the Actrine brand, it's you know, as we say, it's all about protecting, you know, future family projects. The lubrication then as well, it's also resistant to extreme temperatures, so it can be stored in temperatures from anything from -20 to up to 55 degrees. The non-traumatic eyes then, these are the inlets that are on the catheter that allow for the urine drainage. There's no sharp edges on these eyes or inlets, so it again allows for smooth insertion. And again, they're designed for optimal urine drainage. And there's no long-term irritation then with continued use of the Actrine catheters. The no-touch technique then, this is all about patient safety then, so limiting contamination by your hands, which will limit the risk of infection, and it's all about better hygiene. You can see from the picture here. Just around patient autonomy then, again, the catheters come ready and easy to use, and they all have an ergonomic connector. So again, these catheters are designed for, you know, people that might have a reduced dexterity. So the borders and the inlets, they're larger for an easier grip, and they can be opened with one finger. And the areas for cutting, they're enlarged and they're pre-cut, so they're visible. The connector itself, as you can see here, it's winged. So again, it's easy to grip. It's color coded then to indicate the catheter size, and it's they're a universal connector, and again they're a universal color code. The catheter selections then themselves, as I said, the brand is Actarine. The first catheter I'm going to talk about is our mini cath and our mini set. And when I say the word set, it means a catheter with a bag, but again I'll explain that in the next few slides. So our Actarine mini cath and mini set is primarily used by females and pediatrics because it's a shorter catheter. It's a very straightforward and easy use catheter. Again, it comes pre-lubricated, so it's ready for use. Again, there's no water, no mess, no splash, so you can use it anywhere. Again, they're a very discreet product, so they can fit in your handbag, clutch bag, whatever, your sports bag, whatever you're carrying. They're extremely lightweight as well, and they're easy to open. And all the boxes, when you get a box of catheters, there's a discreet pouch that comes in every box. So you can see here the no touch. So when you open the pack, you can hold the catheter then without touching any part, or the connector without touching any part of the catheter, as you can see here with this one. The mini set then, as I said, it's a catheter with a bag. It's a very low profile set, and it's a lightweight set. So as you can see here, it has the very same features as the catheter, but what it has, as I said, it has a bag, and that bag can hold up to 700 mils of urine. There's an anti-reflux valve on all the bags, so you don't have to worry about urine flowing out and maybe leaking. And there's a tear off area then for you can empty the bag. So most patients that will use a bag might be patients that might be in a wheelchair, need to lie down, or maybe need to sit in a chair to catheterize. So again, they come again with nice pouches in the boxes. Our next brand of catheters then would be our Actarine Highlight, and again it's a highlight catheter and a highlight set. So it's your catheter and then your catheter with the bag. These are more they're more widely used, and they're used by both male and female. The catheter itself, typically patients that use the catheter will drain, into a toilet or a urinal, and then the set then will be used then for patients that need to catheterize away from a toilet. So maybe somebody in a wheelchair or somebody needs to lie down. Again, they're male and female catheters. There's two different types of tips on these catheters. The first one is what we call Neelaton, but basically it's a straight catheter, and again, male and females will use this. Our second catheter tip on this brand is a Teeman tip, and that's curved with a little olive tip at the top of it. And males will use this, especially if they have enlarged prostates, because it'll get around obstructions and strictures. So just a summary then on that catheter. Again, it's PVC free, latex free, the non-traumatic eyes. Again, all the catheters are pre-lubricated, so they're ready to use wherever you are. And again, they're designed then for good and reduced dexterity with the no-touch options. And they're a foldable product. And again, they're used in adult and pediatrics. So you can see here, just as I said, how discreet, the catheterized. You can just fold it, pop it in your pocket, and off you go. And again, they come with a discreet pouch. So just basically an overview then of the set. Again, it's an all-in-one concept. So it's the catheter and bag sealed together and folded into a compact size. You have the no return valve, so again, you don't have to worry about leakages. This bag, the Actarine Highlight set, has a bag capacity of 1 litre, so it can hold up to 1 litre of urine. And again, you have your easy opening then for to empty it out then, and just when you empty it then just discard. And then you have your 3 options to open, and they're all pre-cut. So again, just to summarize again, it's foldable, lightweight, and low profile packaging. You only have a catheter and just one outer packaging. Again, your pouch. The last part then of our kind of Actrine DNA is our low environment impact. And Braun are playing a big part in trying to protect our environment in our packaging of all our products. So again, it is a catheter with a minimalistic design. Again, it's just a catheter with one outer layer of packaging. There's no aluminium or no rigid plastic with any of our catheters. They are the lightest product and the lightest catheter out there. So our catheters weigh about maybe 9.7 grams as compared to, you know, some of the competitor products that are up to 20.8 grams. And again, as I said, they're PVC latex free and minimal packaging. So I'm just going to leave you on this last slide, where as it just shows the polar bear sitting in the middle of the sea surrounded by plastic, looking quite sad for himself. So our messaging basically is act green, but act green. So as I said, we are playing our part with, you know, in Braun with our packaging. So that's me and just an overview of the product. So I'm going to hand you over to Roz, which is our clinical nurse advisor, and she'll talk you through what we do clinically.
Thank you, Susan. Hi, everyone. I hope you're enjoying the webinar so far. I just want to take 5 minutes of your time really to go through with you the clinical offering that Braun offers. And this offering is in the community, whether it's in a health centre or the comfort of your own home. So my name is Roz and I'm Braun's nurse advisor for both bladder and bowel, including stoma issues. I've been doing this for over 13 years. So daily conversations for me talking about bladder, bowel issues, leaking, incontinence, urine is all pretty normal to me. My main role really is to teach intermittent self-catheterization and to educate you in bladder and bowel care. And really it's to ensure that you are competent and confident in the product that you are using. Because we at Braun, we're passionate about providing excellent support to all our end users. And really that is my aim. So the clinical service that we provide, we find is paramount for all our patients because, you know, who uses the products do need and should get the support and advice on their bladder bowel related topics that they have. So just to let you know, the service works as follows. So we offer pop-up clinics to support and educate, as I've said, on all urology issues. And as I said that before, that's really in the comfort of your own home or in clinics that I would do. Unfortunately, with COVID, we are quite restricted at the moment, but we are doing these clinics virtually. The way we work with them virtually is if it's something that you feel you will benefit from, then my email and number is at the end of this talk, and feel free to get in contact with me and I can organize a virtual clinic with you, and that's no problem at all. Obviously, our aim is to get these clinics up and running as soon as possible so we can meet our patients face to face. It's important really to link in with your regional care worker in your area. These are a fantastic source of information, the girls and guys that work with MS Ireland, and also the girls around the country, like your Sinead, like your Moira, your clinical nurse specialist. They're full of knowledge, so I would recommend to utilise them. In relation to referrals, the way we work with that is if we require referrals to be able to actually teach you ISC, wherever it may be, as I say, clinic or home. So we would get those referrals from your MS clinical nurse specialist, or if you don't have an MS nurse, you can go direct with your consultant, and we can organise that. And that can be for the face-to-face when they're up and running, or the virtual. So there's my information there. I hope that you will be able to link in with us and that we can help you. And if you feel you need a referral, just go and speak to the girls or direct with your consultant, and we'll get that referral sent to us so we can sort out whatever issues or queries you have. Thank you very much.
Thanks, Ross.
There was one email in from a gentleman who says that he doesn't often get a lot of notice when he needs to make a bowel movement, and he's managed okay so far, but in terms of he's been able to get to the toilet on time, but with restrictions with public toilets and toilets in shops and etc. during the COVID-19 pandemic, he's finding that he's having a bit more difficulty. Do you have any advice for him?
I think really in terms of just with that urgency, you know, he needs to, I would recommend that he starts really just sort of working out how soon, like after he's eating, is this happening, or how often is it occurring around food, drink, and what he's eating and what he's drinking. I think it's the starting point. If it's just, I mean, I wonder actually what sort of stool, is the stool normal or is it sort of overly soft? In that case, then it can look into maybe looking at bulk forming agents that would help, I guess, make the stool more, what's the word I'm looking for, Moira? You know, make the stool more sturdy, if you like, so that he's able to have more control over that. It's really difficult one to manage. That's what I would say. The bowel in general is really difficult to manage, and I would say that it's definitely around trying to establish some sort of a routine. And maybe now, while we're at home, it can be, there's time to maybe make a note of actually what's happening with him specifically. And I would talk to his healthcare professional. If that happens to be me, just pop me an email and I can have a call with you. Yeah.
Yeah, so that piece around the bladder and the bowel diary, I suppose, is very important for a lot of people there who would have asked questions around urgency and that kind of thing too. And
the pelvic floor exercises and that sort of thing, you know, to try and build up that muscle so that he is gaining some control back.
Great. Yeah. Thank you. And then there was a question came in on the live from somebody who said that they are swelling and feel like they are 8 months pregnant and it's really uncomfortable. They can't wear a bra at the moment as it's making the swelling worse. And they said that they're normally a size 12 but are having to wear clothes that are 14 to 16 to manage it. And they're wondering if it has to do with their swallow, as it feels like sometimes their food won't go down.
Is this, sorry, I'm just curious, is this from a bowel or bladder perspective, or is it just
overall swelling? Is it fluid retention?
Yeah, that person might wish to send in some further information on it maybe then if
but if they're having abnormal swelling like that, they need to go to and be assessed. You know, if they're retaining fluid like that at a level where it's coming up their abdomen, you know, or if they think it's fluid or whatever it is, they need a proper assessment. And, you know, as soon as possible, maybe they could start it with their GP, and I'd definitely be monitoring what they're eating and drinking, daily weights, stuff like that.
And just in relation then to drinking water, there was a question about if decaffeinated tea would act as a sufficient substitute for water.
Yeah. Yes.
Yeah. Great.
Keep it as real as possible because, you know, we don't want to be limiting more to people, but yeah.
Yeah, the decaf is great. Yeah.
Great. There's a question in that was emailed in then in relation to kind of embarrassment of bringing up the issue of bowel and bladder with their healthcare team. I think that people will be more at ease today having watched the presentations from both of you, that this is a topic that you're both well versed on and comfortable discussing. But what advice would you give to somebody who wants to bring up that subject in their clinic visit?
Well,
go ahead. No, you go ahead.
I'd start with, you know, sometimes if you can come in, depending on what way you like to hold records, if you want to write down 2 days worth of what you're drinking, what you're eating, what you're peeing, and what your bowel motions are like, that's a good start, because you say, I've actually been keeping a bladder diary or a bowel diary. That opens the conversation, and that's all you have to say. If you know, I suppose to maximize your visits, you have to prioritize what you think you want to talk about. And I would say have 3 things in your head. The consultant is going to see you, you're going to wait for however long, and you're going to have, you know, that window of 15 minutes or whatever it is, and suddenly you're in there and you've loads to say and you can't remember it. So I would have written down, and I would have a top 3 that I want to discuss. But if I didn't feel I got them out, I'd be trying to talk to the nurse afterwards, or even if they're caught up in clinic as well, and you just say, will you ring me? I think I'm starting to have issues with, and you don't even have to say what it is, would you ring me? And now that we're all into telemedicine and doing all the stuff by phone or video conferencing anyway, it'll make that easier. But just prioritize what you want to say. And if you have it written down, or if you use an app, have that to hand and say, I'm worried because, you know, I haven't peed enough, or I haven't had a bowel motion, or whatever it is. Just, you know, use that as a crutch, your record.
And no, I agree.
Sorry, Sinead, I can give you an opportunity.
No, I was just literally going to say, I absolutely agree. I think while it is embarrassing, I guess if this is really causing a problem in your life, it has to be prioritized. And I mean, I realize that you might go to your consultant and it might be a male or a female, you know, and you might not be comfortable talking about something like that. But maybe, I think most hospitals, I believe, have nurse access. And maybe just pop an email or leave a voice message for them and ask for the call, and say what's in relation to, because we're not embarrassed at all to talk about this. This is our bread and butter, if you like. This is sort of our day-to-day stuff that we talk about, and sure, we love talking about it. Tell me more.
We do.
We have a question then that was emailed in about a gentleman who suffers with constipation, and he's noticed that he's losing muscle power to push out his stool. Is there anything that he can do?
It's similar to, you know, I mean, he's having I wonder, is he, I mean, these are very vague sort of responses, because I don't know if he's constipated or if he's having loose stool or what you know, but obviously he just doesn't have that power. So he may well be able to use a laxative that would stimulate that urge for him to go, or you know, whether he needs a bulk formation with a stimulant in it as well. Maybe a stimulant laxative might help with that, but also positioning, all of the same things, positioning on the toilet, going within 20 minutes, trying to go within 20 minutes of a meal, taking 10 minutes, taking your time to do that, pelvic floor exercises. All of that is stimulating. Like, there are while there might be a damage to the message going from the brain to the anus, there are still millions of nerves there, and it's about trying to keep, you know, all of these things from sort of going dormant, and trying to keep the synapses, you know, still firing, if you like.
And then there was another question. There was actually a few questions in relation to the various medications that can be taken, and whether you can either build a kind of a tolerance to them so that they don't work anymore, or if there's kind of long-term side effects of those things that people need to be aware of.
I think you need to change, don't you, Sinead? I mean, you can use stimulants and short-term short-term, like if you need immediate relief, but then you have to look at your history. Say it's your history of how long you've been constipated, how often do you go, how do you load the fiber while keeping the motility of the stool and having it soft enough at the end, without taking all the products, because they do cause cramps for some of them. You do become immune to some of the softeners work. You're trying to get it on every basis. You're trying to improve the motility, you're trying to increase the fiber, and you're trying to get the stool out. But then you need a long-term management plan and not be on them all the time, because they do become less effective over time, or else change them around.
I was going to say change. Yeah. Yeah, I mean, common ones, very common ones use Movicol. A lot of people use it. It's great, and it can be used in the long term. But like that, I think it's about not becoming, if there's any sensation or movement at all, there, not overkilling the medications, because I guess people can call it, your bowel becomes lazy. It almost becomes dependent on the laxative, where you're trying to stimulate some of your own response to that. So
and preserve your own muscle. Yeah.
So I think it is, again, it's hard work. It's, you know, it's monitoring, diet, exercise, all of these things are key part to it. Yeah.
And we did have another one in by email that asked around, this person sometimes has urgency and they can feel a little bit embarrassed about it, and they feel that it's getting in the way of them being intimate with their partner because they're afraid of an accident, and it's really impacting their self-esteem. So maybe, do you have any thoughts on how people can maybe communicate to other people that this might be an issue for them, you know, and how they can kind of navigate that space, I suppose, in terms of communicating that to a partner?
I would say, in terms of particularly around the sexuality side of things, when it comes to you know, bowel and bladder. I mean, it's obviously very embarrassing for people, you know, particularly for a new partner, or if they're, you know, if they're just not comfortable to explain the issues around that. I think, you know, there's definitely facilities through your healthcare provider, through your MS service, where you can be referred to a sexual therapist who can help how to approach this, and how there's other ways of I guess a healthy sex life, and to have that sort of thing. But in terms of specifically for bowel and bladder, we talked about the anal plugs, which would be used during intercourse to obviously prevent leaking, and to give the patient, or to give the person, a bit more security in that they're not going to completely embarrass themselves by this. I see there in the chat, I think it was it's actually Murray's Pharmacy. In the chat there is the place where you can look for all these products around, you know, products that can be used for this. They're very good at actually procuring stuff like that. But I would ask that person to speak to his MS nurse, and perhaps request a referral to clinical nurse specialist for sexual health therapy. It will help around the approach side, you know, in the embarrassment side, and how to maybe look at alternative ways of being intimate with your partner.
Okay.
So I just think as well, sometimes, you know, because things are embarrassing, people stop even talking to a long-term partner. It just doesn't have to be a new partner. And I suppose if they're telling us that there's issue there, well, I would be suggesting, do they talk about what are common side effects in MS? And actually, because sometimes the partners aren't aware, and to the person themselves, they're super sensitive about having an accident. But actually, if they have an open communication and it's brought up that sometimes these are some of the side effects of the symptoms or the medication thing, you'll find that the partner only wanted that said, you know, and actually it's not as big a deal, I suppose, if you can openly communicate. So like we would encourage people to talk together, or maybe to bring in their partner the next time if they want to an appointment, and that these things are discussed openly, because sometimes it's hard to bring them up yourself if your partner doesn't know that what some of the common symptoms are, you know.
Thank you. There was another question emailed in from a lady who said that she had a baby just over a year ago, and she said that at first she was needing to urinate more frequently, but that seemed to rectify itself after some time, but she's experiencing this issue again. She said that she's having trouble trying to figure out whether this is a symptom of MS or something else, or maybe it's still related to the pregnancy and the birth. So would you be able to maybe discuss that a little bit in terms of helping people tease out what the issue might be? And I suppose to highlight as well that not everything is always MS.
That's true. Yeah. It's absolutely. I think I actually had read that email. I think in this situation, I mean, obviously the baby it's only 12 months ago, and you know, carrying a baby weakens the pelvic floor muscles fully. And while initially it might be worse and it can sort of settle itself down, I mean, I'm assuming, obviously making assumptions, that this person is maybe in their 20s or early 30s or 30s. And, you know, they may not, while it never happened beforehand, it's more than likely just a weakness of their pelvic floor. So either it's like doing the Kegel exercises, those floor exercises, they're actually getting referral to a physio. There is actual physio for pelvic floor, and they will do all the specific exercises that can be done to strengthen that whole area.
And then just outrule a UTI, I guess, and look at your drinking, you know, what you're actually, your self-management technique yourself, what you're drinking, what you're eating, and make sure you don't have UTI, I'd say.
Thank you. And somebody else was wondering, they said that they don't currently have any bladder or bowel issues really, but that they want to try and kind of maintain that. And they're wondering if there are any things that they can do to kind of avoid that maybe to some degree. So to help prevent, I suppose, bladder and bowel issues in the future. So what can they do?
Well, I think obviously all the things that we've recommended in terms of like good diet, health, all of those things, exercising, all of those things. And in terms of, you know, people with relapsed remitting MS, you know, the recommendation is that people are on disease modifying therapy. And by being on a disease modifying therapy, you're reducing or eliminating, depending on your response to it, the chances of new lesions or worsening lesions on your spinal cord and brain. And by reducing or eliminating new ones coming on board, you are then preventing one that might be in that main tract that is going to affect your bowel and bladder. So while obviously, you know, it's not a 100% guarantee for everything, it's the recommendation for people with relapsed remitting MS is for disease modifying therapies to try and, while MS the progressive illness, it's to try, and what we are aiming to do is to push out any sort of progression for as long as possible, hopefully well into their 60s, 70s, when it's normal to sort of maybe have a little bit of a bad back or a bad leg. The idea is to try and push it out as long as possible. And by maintaining that and a healthy life, you know, there's no reason why, unless you have, to be MS specific, you need to have damage to the nerves in that pathway. And it's to prevent that. The prevention, the best action we have against any of these symptoms are prevention, particularly in the early days.
Thank you. Another question then was in relation to GP. Can GPs be the referral point, I suppose, in accessing various products for bladder and bowel management?
Yes.
Okay, so that in addition to, so that's something that people can bring up with their GP rather than your neurologist.
Yeah, absolutely. Okay. Yeah.
Brilliant. There was another question in from somebody wondering if prolonged sitting on a bicycle saddle can exacerbate urinary issues.
I actually read that too, and I thought that this is the guy, and I imagine it's similar to, and I don't, the truth is I don't 100% know this specific issue, but just on what I understand is I imagine that maybe if he's spending a lot of time on the bike, that he's having this pressure in that sort of, you know, underneath the shaft of his penis, you know, and that pressure might be pushing and causing maybe an urge or something. I guess similarly like tight underwear or something around the. Okay. My point is that I don't think it's necessarily adding. Sorry, I'm saying this totally wrong. I'm saying this totally wrong. I'm actually just trying to find. I had actually written an answer to that question. I think, or I'd seen it. I think that it may add to just difficulty in passing if he's having a lot of pressure on that all the time. but it wouldn't necessarily be a cause of his MS symptom, if that makes sense. It just might not help the issue. However, you know, I don't know the answer. I don't. Do you know, Moira?
Yeah. No, I would have thought overall exercise is good. It depends if it's an urge to go or a retention. Is it urine we're talking about?
Yeah. So, I think just the saddle. So he's obviously on a,
But I wouldn't have thought, if you need to go, you need to go, whether you're on a bike or, you know, in wherever you are. But if it's retention, I don't think that being on a bike will add to the retention. So I would say, if you're worried about your symptoms, you need to have, and if it's holding urine, then I would arrange for a post-voidal residual and, you know, ask for an assessment, and again get a sample and have it checked for urinary tract infection.
Thank you. So I might just finish up. We might just ask one more question, and then we'll try to get to the rest of them offline, if that's okay. But this person was wondering, with the cold weather, and they're finding they're asking if it can affect urinary symptoms, that they don't have an infection, but when they were walking lately, they involuntarily emptied and leaked. And they were wondering if previously this only happened when laughing or coughing. And that they have been to a physio to do pelvic floor exercises, but if that, can that, you know, with MS sometimes temperature can affect symptoms, so can something like that be an issue then for bladder and bowel as well?
I would have thought it was more the pelvic floor than the cold, if we're certain there isn't an infection, and especially if it happened a couple of times before with coughing, and, you know, that urge incontinence is what it sounds like. So I would monitor myself and see, would it happen again, or what's the time frame. I'd certainly mention it at my next appointment, and once they're happy that there isn't an infection, look at your fluid intake, look at everything we said, and just monitor yourself, but be ready to report it for your next appointment.
Yeah, it sounds like an urge incontinence. I agree, but I mean, you know, it can also be not MS related. I mean, I'm terrible for going out in the cold weather and then needing to find a toilet or turn back home a few minutes early, because it's almost like you feel a bit chill on your bladder, or your bladder just got a shock when you went out if you weren't wrapped up warm enough. But yeah, I'd agree with Moira. Yeah.
That's great. Well, we'll try and get to the rest of the questions offline, if possible. I want to thank Sinead and Moira, Susan and Rosalind for joining us today for this webinar. And we can already see in some of the comments that people are very happy with the kind of information that you've provided today. So many thanks. Thanks to my colleague as well, Mags Ryan, for organising this in collaboration with Braun. Thanks again to our speakers. It was great to have you, and thanks to everybody for joining.
You're more than welcome.
Thank you.
Thanks, Aoife.
Goodbye.
Thanks all.